talking about video off kar do ek second. Today we will be talking about thin endometrium, how to deal with thin endometrium. So now the markers for the positive outcome in IVF, they remain still elusive. These are the maternal age, ovarian reserve and endometrial receptivity, or you can say endometrial thickness. So during menstruation cycle, endometrium undergoes structural changes along with the hormonal fluctuations. One is the menstrual phase, then is the follicular phase, and then is the luteal phase, as we all know. Just everything is getting disturbed. So on ultrasound, endometrial characteristics are endometrial thickness increases in the follicular phase. Endometrial characters changes from a hypoechoic trilaminar one to a compact hyperechoic, and that is post ovulation. A trilaminar endometrium on the day of ovulation trigger is associated with an increased probability of pregnancy, while a hyperechoic character will signal a failure on that day. With the advent of 3-dimensional and 4-dimensional ultrasounds and then Dopplers, now we are at a better position to evaluate the endometrium. So interestingly, endometrial thickness and pattern still remain the most researched parameters for when we are talking about the predictive value of IVF. A healthy endometrium should have a thickness of 6 to 8 millimeter. Endometrial thickness has been used to predict the possibility of pregnancy in ART cycles. A thin endometrium being associated with poor success rates after IVF, irrespective of the causative factor. Even though pregnancy has been achieved at an endometrial thickness of 4 to 5 mm, and with increasing age and compromised vascularity, and with lower conception rate are there, but still you cannot say that you will always get pregnancy with 4 mm. So, but how thin is actually thin endometrium? What is exactly you will call a thin endometrium? Endometrial thickness of 7 mm with ultrasound at the time of embryo implantation is considered optimal in ART. A cutoff value of 6 mm has been considered always. पता नहीं मालती आगे बढ़ता क्यों नहीं है. हाँ. Now the endometrial pattern. Endometrial pattern is graded as grade A, B, C. Grade A is triple line appearance on multi-layered endometrium on the day of the ovulation trigger and suggestive of good receptivity. Grade B is progesterone secretion. Grade B is progesterone secretion, which initiates changes in the endometrium that are reflected as a homogeneous character near the junctional zone and a well-defined central echogenic line. This endometrial pattern seen on the ovulation or the trigger day, this is considered not as good as grade A. Grade C is a homogeneous appearance or non-multilayered endometrium, and it is defined as a non-receptive endometrium, which is not good for the pregnancy. Controversy around thin endometrium. A thin endometrium being associated with poor success rate in IVF, irrespective of the other causative factors, but an endometrial thickness of 4 and 5 millimeter has been shown successful pregnancy. That receptivity may not necessarily be always related to the thickness. A thin endometrium is seen more often in older women, probably because of the decreased vascularity. And there was a study by Kumbhak et al. In 2009, which showed that there were groups of 4, 5 and 6 mm endometrium, all less than 7, and there was no difference in the pregnancy or implantation rate. Now, causes of thin endometrium. Inflammatory causes, acute or chronic infection can lead to the destruction of the basal layer of the endometrium. In India, genital cox is the most common cause of thin endometrium. Healing takes place by fibrosis and it destroys the natural endothelial cells which cannot regenerate through uh, treatment, of whether you give hormone or whether you give whatever treatment, the regeneration of cells will not occur. Then iatrogenic surgical, as we all know, multiple times doing this DNC and all that, and then myomectomy, polypectomy, and laparoscopic myomectomy can also affect if the cavity is open. Then medical indiscriminate use of drugs such as clomiphene citrate. Then idiopathic thin endometrium may not necessarily be secondary to a disease process. It can result from an individual uterine architecture or the intrinsic properties of the endometrium that affects its growth. Now, the thin endometrium is characterized by poor growth of the glandular epithelium. There is high uterine flow impedance. There is decreased growth factor expression, and there is poor vascular development, as you can see in this ultrasound picture. Now, how do we improve the thin endometrium for improving our ART results? For ways to improve endometrial thickness, we still need to travel a long way for the specific evidence-based practice. Intrauterine granulocyte colony stimulating hormone. Endometrium definitely shows better growth of mesenchymal cells and hematopoietic cells in presence of GCSF. A dose of 300 microgram or 100 microgram recombinant intrauterine or subcutaneous can be used in there are so many studies, and most of the studies have shown that with GCSF the endometrial thickness improves. But in the studies you will see that though the thickness has improved or there is a good blood flow, but still this does not turn same result into when you get pregnancy rate improvement does not occur even if the GCSF has shown the increase in the endometrium. That is why the popularity of GCSF has gone away, because of the cost, and then there is no benefit. That is why. Then extended estrogen support. Estrogen thickness can be improved by extending the administration for 14 to 82 days in HRT FET cycles. Then human chorionic gonadotrophin priming, that can be done because it has a positive influence on the endometrial LH receptors, which they say improves the thickness as well as the receptivity. Then there are various vascular promoters like pentoxifylline 800 milligram per day, tocopherol 1000 milligram per day, sildenafil 50 to 100 milligram per day, L-arginine 6 milligram per day, then low dose aspirin 75 milligram per day. Intrauterine autologous platelets, rich plasma infusion, intrauterine administration of bone marrow stem cells, then luteal phase support with GnRH agonist, pelvic floor neuromuscular electrical stimulation for improving endometrial thickness, then various other regenerative medicines like stem cell therapy. I don't have any experience of all these things, but still, these are the options we have. Management of thin endometrium in assisted reproduction, a clinical practice guideline which came from the Canadian Fertility and Andrology Society. This they have said that the thickness of the endometrium measurement should be always same. It should not be operator dependent. In the first picture you will see that from the fundus you are seeing the endometrium till the cervix, so that picture should be taken and then you measure from outer to outer. So operator dependence should be less. Then next is that thin endometrium uterine sorry ना आगे पीछे बिल्कुल जा नहीं रही है. Potential pathological things are most of the times whenever there is any pathological thing you find there is Asherman, and then operative treatment is must in those cases. Thin endometrium may not impact the pregnancy outcome in ovarian stimulation cycles. The most observation studies do not show a difference in pregnancy rates, and thin endometrium at different cutoff. A systemic review did not find a difference in the endometrial thickness in patients who were pregnant versus who were not pregnant. Then in fresh IVF embryo transfer patients, it was found that endometrial thickness, if less than 8, it may have a negative impact on the pregnancy and live birth rate. So patient must be counseled before, when you are doing the ultrasound before implantation. There are no studies which compare different endometrial preparation protocols for FAT, and then thickness according to those protocols. There are no such studies available. Then in different RCTs, it has been shown that we are so fond of using ecosprin, sildenafil, but the RCTs and different trials, they have shown there is no benefit of all these things. So according to the RCTs, the thin endometrium will remain thin whatever you do, and over time the results will also be affected as so GCSF. Some people are still trying GCSF, and there may be people in our expert group, who will be telling about their experience about the use of GCS. So in my experience, what I am doing is, we are using EcoSprin, maybe 75 to 150. Then high dose of E2. I have maximum dose of E2, which I have used is 8 tablets per day of this estradiol valrate. That is 16 milligram per day. But that prolonged therapy for 14 to 82 days, that we have never done. I have gone up to, I think, 16 or 18 days maximum, not later than that. If it is going later than that, I am cancelling that cycle. Then CoQ, I am definitely using. L-arginine I am using. Sildenafil vaginal I am using. Then amino acid rich preparations, off and on I use. GCSF, though I use sometimes and do get results, but still I am not very pro to use this drug because of the cost and the result, as we all know, because it may not turn out to be a positive when we call pregnancy. Then hysteroscopy, obviously, that we need to do. If she's making thin endometrium, a pre-IVF hysteroscopy is a must. And I have no experience of using PRP or stem cells in the endometrial cavity. So to conclude, endometrial thickness impacts multiple parameters involving implantation and pregnancy. The chances of successful pregnancy reduces with endometrial thickness below 6 millimeter. The the reason is that there is low vascularity, high impedance to blood flow. There is reduced VEGF. There is less angiogenesis, and thus low invasion and poor implantation. Thin endometrium is known to disturb placentation and vascularity, which can be a reason for early abortion. Also, patients with thin endometrium can present with placenta accreta. It's observed that HRT for endometrium conditioning has shown better results than fresh FET, fresh embryo transfer. It's important to consider all factors and recommendations to employ a therapy for endometrial improvement. So I think that will be all. Thank you so much.
And I will say that after your presentations, all experts may have a difference of opinion from you. So let me ask
Definitely.
Brigadier Sharma, sir, how much thin endometrium bothers you, and what is your tips?
See, basically, thin endometrium is of two types. One is with very poor vascularity, and one is with a good vascularity. So we should do the color Doppler and see. So if
Yes.
the vascularity is good, and even if the endometrium is thin, and despite all your efforts, it is not improving, then you can still do the embryo transfer. But if the endometrium is thin and the vascularity is poor, so that patient will not be benefited by doing the embryo transfer. So firstly, we have to differentiate these two type of thin endometrium. And secondly, the thin endometrium should not be associated with any adhesions, because adhesions mean fibrosis. So that also will not be benefited by all this, sildenafil and extra uh, things like GCSF, etc. Now, how you measure your endometrium. Madam had rightly pointed out. You must take an exact sagittal section, which should include the cervical canal and endometrium till the fundus in one plane. Now, many times when the patient is having endometriosis or PID, somehow the uterus may be rotated, the upper part in its own axis. So you will not get a triple line picture. What you see is like a HSC type of a picture on a ultrasound. Triangular view you'll get it. So under those circumstances, it becomes very difficult to exactly measure the length of the endometrium. Under those circumstances, possibly one has to do internal examination and correct the uterus and then do the ultrasound. That is one way of doing it. Or you make your abdominal probe or your transvaginal probe in such a fashion that you get exactly the cross section, not the cross section, the sagittal section of the endometrium. Now, Madam had pointed out, the types of endometrium where, it's a typical triple line, and then, haziness starts from below in the basal layer upwards, because the progesterone effect starts from the basal layer towards the inside. So the more the progesterone, and the more, you'll find that the basal layer will be ecogenic. It will not be exactly a triple line. And then if it is too much, then it is totally homogeneous, the third type which she mentioned. So under those circumstances, one should do the progesterone level. And even if there is no corpus luteum from where the progesterone is coming, we may not know. But if the progesterone level is high, so that cycle we should not do the transfer. And regarding this subcutaneous GCSF versus intrauterine GCSF, because some people mention, okay, you can give subcutaneously also. Now, my experience with the subcutaneous GCSF is it can cause a lot of bone pains to the patient. You give it in your OPD subcutaneously, and in the night or early morning next day, she will say, Doctor, I'm having so much of severe pain in all my bones. Because possibly GCSF, stimulates bone marrow and it causes pain in the bone. So I normally have stopped giving now. After, getting all the odd hour telephone calls, I do it only intrauterine in the follicular phase, GCSF. And the cost of GCSF, it's around say 1,000 rupees, or maybe if you can negotiate with the company, you may get cheaper also. It's not very costly. So twice at least one can do the intrauterine installation in the patients where the repeated endometrium is thin. One can go for extended, estrogen. So I have done many times on day 24, day 26. Because again, if I allow her to have a bleed or give her withdrawal bleeding, the next cycle will be the same story. So whatever we have to do, I think once we started, we should make sure that we achieve the lining and then we do it. And she mentioned very nice, new system about the electrical stimulation of the uterus, and to give the low voltage electrical stimulation. Now, if we remember our basics of semenology, the semen has got prostaglandin E2 in high concentration. Earlier, when the IUI was not available, so some people tried to do the intrauterine insemination with the neat semen sample, and the patient used to get very bad cramps because of that, because of prostaglandins. So that means prostaglandins will cause uterine contractions. So we should encourage these couples to have a regular intercourse so that this prostaglandin would leach into the uterine inside and would cause uterine contractions. And those uterine contractions is sort of an exercise for the endometrium as well. And you will get the same result as you would get by electrical stimulation causing contractions. So these couples should be advised, because normally they say, okay, now the doctor is going to do ET or FET. Well, there's no point of doing any intercourse. So this should be allowed with this reason also, because prostaglandins would help in uterine contractions and would also improve the endometrial thickness. Now, sometimes when we are doing the endometrial study, we find that yesterday the lining was 6.5, and we are saying, okay, let's make it more than 7. We'll call her after 1 or 2 days, and you find that instead of increasing, it has decreased. And not only it has decreased, the pattern has changed now. So initially, what you saw was a triple line, and after 2 days, you find that now the haziness has started from the, the basal layer upwards. Now this has happened because of the progesterone. The progesterone, when we, try to recollect our old basic knowledge, it causes little desiccation of the endometrium. The estrogen causes water collection in the endometrium, so the endometrium, the stoma gets swollen up and all. But, and the estrogen is also mitogenic. While the progesterone has got an anti-estrogenic effect, it will stop the mitogenesis, the cell multiplication in the endometrium will stop. And secondly, it also causes desiccation. So some amount of dehydration of the endometrium. So you will see that, the endometrium has reduced in size. So not only the pattern has changed, even the thickness has also reduced. So that is also not a good sign. So we should, abandon that cycle, give a dog bleeding and then do it again. So these are a few of my thoughts regarding this. And lastly, the sits bath, so that that will also increase the circulation and would possibly help in the development of endometrium, which I do it regularly to all my patients.
Dr. Yukti has asked two things. Why there is a difference? Dr. Poonam has said for a fresh cycle it should be 8 millimeter plus, and for a frozen cycle it should be 7 millimeter plus. Any comment on this? And she was also telling, any luteal phase agonist injection, can it improve the pregnancy rate? Your comments on it.
Now the thing is, for the FET, you may require a thinner endometrium, and for a fresh, you may require a thicker endometrium. Now the reason is not well understood why it should be so, because finally it is the embryo who is going to implant, and I would prefer the same endometrium whether it is a fresh or is a frozen embryo transfer. Now, giving GnRH agonist during the luteal phase, how it is going to work? It is basically going to release FSH and LH, which would work on the corpus luteum, and if it is a fresh cycle, and and that would release more estrogen and progesterone. So it will maintain the estrogen progesterone levels. While in FET cycle, it will not work because there is no corpus luteum there.
Thank you very much, sir. I think I will give my own comments about this. Thin endometrium is a reality. And as pointed out by Dr. Poonam, tuberculosis must be ruled out. And histoscopy is also, should be done to see to it that the adhesions are not there at all. I find, whatever you give, I have a good faith as far as GCF is concerned. I look at it as part of a stem cell therapy kind of a thing, which has been coming in this particular form. Normally, what we do in a thin endometrium cycle, we give a injection somewhere on the 6th or 7th day, and then we give it on the 9th day. On the 9th day, when we're giving it, we give intrauterine 0.5, and the rest we give subcutaneously. And then see the response, and if you find the response is good and it has made to something like 6.5, that is the time that we give a PRP. Otherwise, we don't give a PRP. I'm a very strong advocate of telling that 7 millimeter endometrium, if it is not there, then you should not you should counsel your patient that in IUI the endometrium is not there, the success may not be there. In IVF we don't transfer, we are very clear about it. This is what I feel about it. Some may say 4 millimeter, 5 millimeter, 6 millimeter, it has never happened with us. So that is one thing about it. Secondly is that in the end, when everybody's expert's turn is over, then I will ask Dr. Jyoti Agarwal also to make up a mind to speak on this. I will say that I also feel that the giving ecosprin, L-arginine and sildenafil and all that probably do not make much of difference. I feel if there is a good ovas are there, good endometrium should be there. If the endometrium, in spite of it, if you whatever you may do, 60% you will be able to make a good endometrium. I also feel that I have never found that if you've made a good endometrium, the pregnancy is not there. So pregnancy hona hai to hoegi. You've tried your best. Ye कहना कि बदले कि because of estrogen you have supplemented or because of GCF you've added, pregnancy will not occur in that particular pregnancy. I will differ with it, because all of us are continuing to do that, and we find both in IVF cycles and in IUI cycles supplementation of estrogen works, and supplementation of GCF also works. This is what I have to say. I have seen we also do not drag to 84 days as far as the estrogen supplementation is concerned, but I've seen 21, 22, 23 days one can take these patients. So I'm not negative about. I'm pretty happy with GCF, and as well as on the PRP. We only indulge if we find that endometrium is 6 or 6.5. That's the time that we give PRP, and we find that the good endometrium is there on the day of the ET. Almost 8 millimeter. So now I will ask Dr. Aruna Saxena to make her comments. Dr. Aruna Saxena.
Ma'am, I use GCSF left and right. I'm very happy with the response. But one practical point I would like to mention here: whenever you give GCSF to your patient, intrauterine or subcutaneous, I always give intrauterine. Warn your patient about she can be having fever next day, because most the patient call.
Yes, and you have to do a TLC also may be raised. So you must have a baseline.
Yes, TLC is drastically raised, and if you get TLC along with patients are really worried. So you have to explain these things to patient, number one. Number two, when you measure the endometrium, endometrium is contracting. So there is peristalsis in the endometrium. So a practical point is that if peristalsis is too high, then wait for the peristalsis to settle, then you measure the thickness. I remember when Dr. Jyoti, when I was bringing my patient at my clinic, bringing it to you, I would say, Dr. Jyoti, 86 mm, Dr. Jyoti, ये तो खाली 4.5 mm. Then later on I realized that was the point. I measured at a different point of time, and she measured at a different point of time. That's one thing. Number three, which I do very often, I do hysteroscopy in the same cycle. If patient has thin endometrium, I do hysteroscopy immediately after period, do the PRP or GCSF along with the hysteroscopy, and then repeat it if the patient has very thin endometrium. Another thing, like about the thickness, I mean, this is also documented that for a particular patient, endometrial thickness, it could be different for every patient. So you have to measure the thickness in the previous cycle before IVF, and then you should comment whether it's thin or thin, because the particular patient, maybe the 6 mm is normal. So we should not go by the figures, but what is optimal for that patient, probably that will make more sense. That's it.
Have you found Dr. Aruna Saxena endometrium of 5 and 6 patients getting pregnant?
Yes, ma'am. 2 of my patients, one at 5.9 with twins, carried till 36 weeks, and other at 5.1 carried till 31 weeks.
Dr. Shweta, what is your experience in thin endometrium?
Ma'am, like ma'am mentioned that we should always compare her endometrium of previous cycles. So if there is a patient with me who has an endometrium of around 6 to 7, and I'm finding that it has poor vascularity, I do get back to her previous papers from other IVF specialists where her IUI or any other follicular monitoring cycle has been done, and then collaborate with those records. If she's had a previous 10, 12 mm, then definitely either cancel the cycle. And ma'am, secondly, GCSF, yes ma'am, I think it works wonders. And we should always see the result of the GCSF after around 24 to 30 hours. It takes that much time for the endometrium to build up.
I think when you rightly said, we have made a policy anytime any patient of IVF or IUI is coming to us, we definitely see to it and we record in a special place which day, how much was the endometrium. So you get obsessed about, thickness of endometrium, and in cycles when you find that she was earlier good endometrium and this time she was not picking it up, it's good to cancel that particular cycle. I think I will agree with you. Dr. Arora, are you there? Dr. Arora? I think I will ask Dr. Jyoti Agarwal to make a comment as far as thin endometrium and her experience is concerned. Dr. Fatella, I'm coming to you after this.
Yeah, as much discussed about Ecosprin and GCSF, we have stopped using Ecosprin nowadays. I'm a strong believer of GCSF, and we are using it for most of our IVF cycles. And I find the results are quite good. As far as the cost is considered, it's not much, 800 to 1,000 rupees. It's quite approachable, and 1 or 2 injections are sufficient for it. Besides, whatever we have discussed so far, what we do if the thin endometrium is not improving, and that also repeatedly, then I do a serum estrogen level also to see whether what estrogen she is taking is, what is the bioavailability of that estrogen. If that estrogen, serum estrogen shows poor result, then I'm a strong believer of changing the route of the estrogen, and I start giving it subcutaneously, and I find the result of estrogen gel is very good. The endometrium really improves with it, and I'm quite happy with it. And as far as PRP and stem cell, we are using it, but it's still a research process. So
yes, we are using it. We are using it. Dr. Anupama. Dr. Anupama Fatella, yes. Want to make any comment?
Good evening, ma'am. Yes, I just wanted to say one thing, ma'am, that this level of 7 mm, which has been traditionally cut off, I personally feel that it depends on the patient to patient. I have seen a few patients who are thin built, who have teeny mini uterus. In those patients, even 6 mm is okay. I have seen a few of my hypo patients who had never bled earlier, and I had made their endometrium linings 2-3 cycles, and then started their donor cycle, and then later on transferred. In those patients, I have felt that even 6 mm, it is the pattern which is more important rather than the thickness. And even I endorse that. I have got pregnancies in such patients which their 6 mm is usual, that you should not expect a standard level of 7 mm, 8 mm in such patients. And the second thing which I wanted to say was that once the progesterone is added, there is always a certain amount of compaction which occurs in the endometrium, and that compaction falsely gives some people stop cancel the transfer that the ET at that particular day was 8 mm and now it has come down to 6.5 mm, so we cancel it. But we should understand that after progesterone, the endometrium is bound. And in fact, whenever there is compaction of the endometrium, it rather holds the embryo in a better way, and it is a rather good sign. Then when the compaction is occurring, we must go ahead with the transfer. Thank you.
I think I'm glad that you reiterated the point which was made by Brigadier Sharma, that one should really not get upset if there is a slight decrease in the endometrium, and this is because of the effect of progesterone. But I think this observation is that when the endometrium triple line gets fuzzy, the chances of pregnancy becomes less, and I think that is good observation. Anybody wants to make any last minute comments? So what we will say, Dr. Poonam and
Dr. Nisha ma'am wants to say something.
GCSF, so you should worth trying it. It has got a merit, and we find a good results with this. And PRP we don't use left and right. We only use, once we have find a good effect with the GCSF, then we use PRP in such patients. And again, I want to tell you is, please have a baseline when you're planned. Please have a baseline TLC. And as doctor said, that next day temperature will be there, and the rise in the TLC will be enormous, 25,000, 24,000. So don't get upset with that. This is the part of the injection. Dr. Bhatnagar, you want to say something? Yes.
Yeah, ma'am, I just want to say, sometimes we have seen that if nothing else is working and we go back to natural cycle, we do a natural IVF transfer. We prepare the endometrium, we let the egg form in that cycle. That sometimes gives the best result. We do a lot of natural cycle transfers. Results are amazing.
Well taken this particular point. So, Dr. Poonam Goyal, your presentation had invited so many comments, and I'm sure we will ask Dr. Sardana to make a summary, otherwise the recording will be definitely there. So, I think we all go wiser after this particular presentation. I go wiser that I should not get stuck, but I'm obsessed. In IVF, I'm not going to transfer if it's not 7 millimeter.
I have one question from Sir before Shweta wraps it up. Sir, any experience of using it for 80 days or 82 days that I found in literature?
No, actually, literature they are given, but these are all anecdotal cases. It's not regular. But yes, sir, around 25 days, 27 days, we have done it. And today also have put a patient on progesterone from today. And I'll be transferring
Because
that case.
I was thinking if I am going to give it for 80 days something, so she may have, threshold bleed in between, spotting,
No, that we have to
etc.
see. So if it is growing all right slowly, and if your progesterone levels are in the range, you can transfer it. But if you find that the progesterones are going haywire now, or
Then
you have malic, then you have to cancel it. Now, see, remember one thing: it is not only the endometrium for pregnancy; it is the embryo. When embryo can grow in the fallopian tube, it can grow in the ovary, it can grow over the omentum. Where is the endometrium there? So we have to look into that part also. So
Very
the
nicely said.
quality of the embryo is very, very important. So if the quality of the embryo is good, even 6 millimeter you may get the pregnancies, and if the quality is not good, even with 10 millimeter you may not get the pregnancy. So we have to look that part as well. And now, though the government has put a cap on number of embryo transfers, maximum you can do 3. But sometimes, earlier, when such cap was not there, I used to get patients who had, repeated failures because of thin endometrium. So my belief was there, if the soil is bad, put more seeds. Now I cannot put more seeds, so I put 3 blastocysts, not more than that. So this, because there are some cases, where whatever you do, the endometrium is not increasing, and she has got a repeated history of failures. Under those circumstances, the one can put more embryos, but right on 3 only.
डॉक्टर साहब आपके शिष्यों का भी इस पे बड़ा असर है अभी तो 3 का कैप आ गया तो ब्लास्टोसिस भी वो 3 डालेंगे इसमें क्या जस्टिफिकेशन
Madam, because the thing is, the endometrium, the whole of uterus has got endometrium, but whole of uterus may not have a equally healthy endometrium. So by putting more seeds, maybe some seeds will fall at the right place and get implanted. Because with surrogacy now, which is next to impossible, maybe that is the answer, madam.
I can see Dr. Seema, you want to make any last minute comment on thin endometrium? Your personal experience, no, not bookish.
No, sir, ma'am, but just I wanted to know one question, sir. Because of the repeated cesareans are there in the patient, we have seen many of the patient coming with the fluid in the cavity, and that too after 7th, 8th day of the stimulation, and that is in connectivity with the isthmocele. So, can we transfer in that cases, or we have to abandon that patient?
No. The thing is, if there is a fluid, so they will not be able to make contact with the endometrium. So you have to remove that fluid. Now, how do you remove that fluid is very, very important. Either you repair the isthmocele laparoscopically or whatever way you want to do it. Either you do that, or sometimes even you put your
By IUI cannula. In that the same cycle only.
cannula on the fluid by IUI cannula, and in the you can then do the embryo transfer in these cases also. But on the day of but this should be done before you start your progesterone, because otherwise what will happen, you should not do it on the day of embryo transfer. So you aspirate out, start the progesterone. Progesterone will make the mucus thick and tenacious, so it will not go back into the uterine cavity, and then you can see whether cavity is dry, and then we'll do the embryo transfer.
By and large, Dr. Seema Sehgal, if the fluid is there, you have to look in. आपकी कुछ वर्कअप में कमी है, ठीक है? वर्कअप में कमी. I think this has been a tremendous response. Dr. Poonam was reluctant on thin endometrium, but you could see how much is the response that people are sharing their things. I'm glad that this presentation was made.
Thank you,
Is
ma'am.
there Shivani here?
हाँ शिवानी आ गई मैम.
Acha, chali. So I think Shivani is going to. Dr. Sardana, you wanted to say something?
No, ma'am. I was just thinking if we. I mean, should I talk about the summary right now or like we?
No.
start
I will give you the.
I can
recording.
share my
आप
own
summary बनाओगे?
simple experience.
हाँ, ठीक है.
Uh,